Welcome to the Module 8 Synopsis. Today we're going to talk about anxiety disorders. Take a peek at those Module 8 objectives. Read through them, make sure you feel like you've met all of them. If you feel like you haven't, go ahead back through the materials and see if there's anything in there that can help you make the connections. Which module objective did you most enjoy learning about? Let's go over the basics of anxiety and anxiety-related disorders. Anxiety is a universal human experience that includes feelings of apprehension, uneasiness, uncertainty, or dread, resulting from a real or perceived threat. Different levels of anxieties: mild, part of everyday living, and they can help an individual use their senses to perceive reality in sharp focus. Moderate anxiety. Anxiety increases, the perceptual field narrows, and the ability of the individual to fully observe their surrounding is diminished. Severe anxiety. The perceptual field of a person experiencing severe anxiety is greatly reduced. Panic. Panic's the most extreme level of anxiety, and this results in significantly dysregulated behavior. Coping with anxiety. People use several strategies to cope with anxiety. Coping strategies are an action, a series of actions, or a thought process used to address a stressful or unpleasant situation or modify one's own reaction to such a situation. Coping strategies are classified as adaptive or maladaptive. Defense mechanisms are reaction patterns used by individuals to protect themselves from anxiety that arises from stress and conflict. What are some risk factors for anxiety? Well, there are some general ones: temperamental traits of shyness or behavioral inhibitions in childhood, exposure to a traumatic life event or a traumatic environment in early childhood or adulthood, or history of anxiety or other mental disorders in biological relatives. All right, some anxiety-related disorders. So anxiety disorders are a common mental health problem. Around 19% of adults and 31% of adolescents have anxiety disorders in the United States. There is generalized anxiety disorder. This is excessive anxiety and worry recurring on more days than not for at least 6 months about a number of events or activities like work or school performance. Symptoms: restless or feeling keyed up or on edge, easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbances. Social anxiety. This is a marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. These are things like social interactions, like having a conversation or meeting unfamiliar people. Panic disorder. People with panic disorder have recurrent, unexpected panic attacks. Panic attacks are sudden periods of intense fear that come on quickly and reach their peak within minutes. There are some DSM-5 criteria for panic attacks: palpitations, sweating, trembling and shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensation, paresthesia, which is numbness or tingling sensations, derealization or feelings of unreality, feelings of losing control, fear of dying. Phobia-related disorders. A phobia is an intense fear or aversion to a specific object or situation, like flying, heights, animals, receiving an injection, or seeing blood. Although it can be realistic to feel anxious about certain objects and circumstances, the fear felt by people with phobias is out of proportion to the actual danger caused by the situation or object. Separation anxiety disorder. Now, a lot of people associate this with children. Not true. It can happen in adults as well. Separation anxiety disorder: individuals have fear about being separated from people whom they are attached. They often worry that some sort of harm will happen to those with whom they are attached while they're separated. The fear leads them to avoid being separated from their attachment figures, and they also avoid being alone. Selective mutism is a rare disorder associated with anxiety. It occurs when people fail to speak in specific social situations despite having normal language skills. Selective mutism usually occurs before the age of 5 and is often associated with extreme shyness and fear of social embarrassment. Each of these disorders has their own characteristics. Which characteristic surprised you the most? Treatments for anxiety. Let's start with psychotherapy or talk therapy. We've talked about this in previous modules. It can help people with anxiety disorders, but to be effective, psychotherapy has to be directed to the person's specific anxieties and tailored to their needs. Medications. Medications don't cure anxiety, but they're used to help relieve the symptoms of anxiety, panic attacks, extreme fear, and worry. The most common classes of medications used to combat anxiety disorders are anti-anxiety drugs such as benzodiazepines, antidepressants, and beta blockers. Considerations for medication therapy in anxiety disorders. Black box warning states that concurrent use of benzodiazepines and opioids may result in profound sedation, respiratory distress, coma, and death. Keep this in mind when you have somebody that has multiple comorbidities and polypharmacy. Adverse side effects. Children and older adults are more susceptible to the sedative and respiratory depressive effects of lorazepam and may experience paradoxical reactions such as tremors, agitation, or visual hallucinations. Overdose. Overdoses of benzodiazepines is manifested by varying degrees of central nervous system depression ranging from drowsiness to coma. If an overdose occurs, dial 911 or call a rapid response in an inpatient setting. Once again, patient education is of the utmost importance when we're talking about medication interventions. Clients should be cautioned that driving a motor vehicle, operating machinery, or engaging in hazardous or other activities requiring attention and coordination should be delayed for 24 to 48 hours following the administration of benzodiazepines or until the effects of the drug, such as drowsiness, have subsided. Alcoholic beverages should not be consumed for at least 24 to 48 hours after receiving lorazepam due to the additive effects on the central nervous system. Support groups. Support groups can be helpful for individuals experiencing anxiety disorders by sharing their problems and achievements with others that are experiencing similar symptoms. The other benefit of support groups is that they can see how other people are dealing with similar issues to their own. Stress management and coping strategies. These techniques help people with anxiety disorders calm themselves, and it enhances the effects of therapy. Psychoeducation. Clients should be educated about symptoms of their diagnosed anxiety disorder and techniques to manage it with psychotherapy and medications. For some individuals, even being aware that something is a symptom of anxiety, naming it, and connecting it to anxiety can help reduce the intensity of the anxiety. Let's talk a little bit about obsessive compulsive disorders. This is a common chronic disorder in which a patient has uncontrollable recurring thoughts, obsessions, and or behaviors or compulsions they feel the urge to repeat over and over. These compulsions often temporarily relieve the stress and tension of the obsession. Signs and symptoms of OCD can interfere with all aspects of life: work, school, personal relationships. They come and go, sometimes they ease over time, and sometimes they get worse. Obsessions: fear of germs or contamination, unwanted, forbidden, or taboo thoughts involving sex, religion, or harm, aggressive thoughts towards self and others, or having things symmetrical or in perfect order. Compulsions: repetitive behaviors that a person with OCD feels the urge to do in response to an obsessive thought. Excessive cleaning and hand washing, ordering and arranging things in a particular way, repeatedly checking on things like checking the locks on the doors or seeing if the oven is off, and compulsive counting. Not all rituals or habits are compulsions. Everybody double checks things sometimes. For example, people double check that their doors are locked as they exit the vehicle. However, a person with OCD generally exhibits different characteristics. They spend at least an hour a day on these thoughts. They can't control their thoughts or behaviors, even when those thoughts or behaviors are recognized as excessive. They don't experience pleasure when performing the behaviors or rituals, but may feel relief. They experience significant problems in their daily life due to these thoughts and behaviors. The specific causes of OCD are unknown, but risk factors include genetics, brain structure and functioning, and environmental factors such as adverse childhood events. Treatments. So OCD is typically treated with medications, psychotherapy, or a combination of both. Although most patients with OCD improve, some patients continue to experience symptoms. Medication. SSRIs are used to help with OCDs. They are often higher daily doses in the treatment of OCD as opposed to depression, and it could take 8 to 12 weeks to start working. Psychotherapy. This can be effective for adults with OCD, and research shows that certain types of psychotherapy, like cognitive behavioral therapy, and other related therapies like habit reversal training and exposure and response prevention, are effective in reducing compulsive behaviors. So there are other treatment options. One of those options is repetitive transcranial magnetic stimulation, or RTMS. This uses a magnet to activate the brain. Unlike electroconvulsive therapy, which electrical stimulation is more generalized, which we've talked about, RTMS can be targeted to a specific site of the brain. The session lasts 30 to 60 minutes, doesn't require anesthesia. And as with many of the disorders we've discussed, psychoeducation. In addition to teaching clients about the symptoms of OCD, prescribed medications, and other treatments, nurses should teach the clients how to manage stress and anxiety associated with OCD. Create a consistent sleep schedule, make regular exercise a part of your routine, eat a healthy, balanced diet, and seek support from trusted family and friends. So, what did you learn about RTMS in relation to OCD? Post-traumatic stress disorder is diagnosed in individuals who have been exposed to a traumatic event with chronic stress symptoms lasting more than 1 month that are so severe they interfere with relationships, work, or school. Symptoms of PTSD: re-experiencing, avoidance, arousal and reactivity, and cognition and mood. Re-experiencing symptoms include things like flashbacks and bad dreams, avoidance, staying away from places, events, or objects that remind them of the traumatic experience, avoiding thoughts or feelings related to the traumatic event, arousal and reactivity symptoms, being easily startled, feeling tense or on edge, difficulty sleeping, angry outbursts. Cognition and mood symptoms: trouble remembering features of the traumatic event, negative thoughts about oneself, distorted feelings of guilt or blame, loss of interest in enjoyable activities. So, lifespan considerations. PTSD is going to manifest differently in young children. It's a little bit more similar to adults when they're adolescents, but in children, it's bedwetting, forgetting how to talk. Adolescents and teens, even though they display some of the same symptoms as adults, they could also become disruptive, disrespectful, and that could be their significant manifestation. Risk and resilience factors. Anyone can develop PTSD at any age, including veterans, children who have experienced trauma, or adults who have experienced physical, sexual assault, abuse, accident, disaster, being a refugee, or some other disastrous event. Not everyone with PTSD has directly experienced an event. Sometimes people develop PTSD when someone they love has a major event or if they witness one. Risk factors: living through dangerous events, being injured, seeing another person hurt, or seeing a dead body. Adverse childhood experience, no social support after the event, and history of mental illness. Resilience factors that promote recovery: receiving support from others, finding a support group, learning to feel good about one's own actions in the face of danger, having positive coping strategies, and being able to act and respond effectively despite feeling fear. Treatments for people with PTSD include medication, psychotherapy, or a combination of both. Everyone's different, and PTSD affects everybody differently. Antidepressants are commonly prescribed for PTSD symptoms, and they can take from anywhere from 6 to 12 weeks to be effective. Psychotherapy. This can occur one-on-one or in a group setting. It typically lasts 6 to 12 weeks, but it can continue for as long as the individual finds it helpful. Therapies like cognitive behavioral therapy and eye movement desensitization and reprocessing are psychotherapy techniques that are helpful in PTSD. What did you learn about EMDR in relation to PTSD? Let's apply the nursing process to anxiety disorders in a quick chat. Assessment. Symptoms associated with fight or flight include restlessness, altered concentration, attention, or memory, diminished ability to learn or problem solve, hypervigilance, fear, irritability, hand tremors, increased perspiration, quivering voice. Screening tools: Use the Generalized Anxiety Disorder in Adults scale. It's a common tool for measuring anxiety, and high stress may indicate generalized anxiety disorder or panic disorder. Make sure you take a look at that diagnostic and lab work. Cultural considerations. Beliefs can affect an individual's expression of their feelings of anxiety. Of an example of culture-mediated response related to anxiety and panic disorders is attack de nervios. I think I said that right, or ADN. That means attack of the nerves. It may be exhibited in Hispanic populations. Symptoms of ADNs can vary widely but are typically described as experiences of distress characterized by a general sense of being out of control. Diagnoses. Anxiety is a NANDA 1 nursing diagnosis and described as vague, uneasy feelings of discomfort or dread accompanied by an autonomic response, a feeling of apprehension caused by anticipation of danger. It is an alerting sign that warns of impending danger and enables the individual to take measures to deal with the threat. Outcomes identification. The overall goal for anyone experiencing anxiety is to reduce the frequency and intensity of the anxiety symptoms. SMART outcomes are individualized to the client's diagnosed condition, situational factors, and current status. Planning outcomes will be small, attainable steps that can help the client gain a sense of control over their anxiety. Example of SMART outcome. The client's vital signs will return to baseline within 1 hour. The client will identify and verbalize symptoms of anxiety by the end of the shift. Planning interventions. The client should be encouraged to participate in planning outcomes and interventions tailored to their situation and needs. This will increase the likelihood that the interventions will be successful. Keep in mind that clients with severe anxiety or panic may not be able to participate in planning, and they rely on the nurse to take the directive role. Implementation. Safety. If a client is diagnosed with risk for suicide, interventions to maintain their safety receive priority. If a client's anxiety continues to escalate and they become agitated, measures must be taken to keep them and others safe. The nurse may find that administering prescribed medications, initiating time in a quiet room, seclusion, or restraints are required. Mild to moderate anxiety. The nurse can reduce the client's anxiety level and prevent escalation by providing a calm presence in a quiet environment, acknowledging their feelings of distress, and actively listening. Severe anxiety to panic. A person experiencing severe anxiety to panic is often unable to solve problems or grasp what is going on in the environment. The nurse should also remain with the client experiencing acute, severe, or panic levels of anxiety. Therapeutic communication should focus on helping the client feel safe. Firm, short, simple statements using a slow, low-pitched voice are helpful. Evaluation. Refer to the individualized SMART outcomes established for each client when evaluating their effectiveness in the interventions of the care plan. In general, is the client experiencing a reduced level of anxiety? Do they recognize their symptoms are related to anxiety? Is the client successfully implementing adaptive coping strategies? Is the client adequately performing self-care activities? Are they able to maintain satisfying interpersonal relationships? And is the client able to successfully function socially, occupationally, or in other important areas of their life? That's it for the Module 8 synopsis. Nice work, everybody. Keep it up.